I'm inviting the next chairperson, Dr. Shaukat, who is MBBS in diabetology, and we are having Dr. Alvina with us. She is a consultant diabetologist at S. Hospital, Mumbai.
So after that very interesting discussion on insulin, despite all the innovations happening in diabetes, our first lecture is by Dr. Brij Maka, and we are going to be talking about Icarus, which is now completing 25 years. Dr. Brij Maka, I just like a short introduction to him. And Dr. Maka doesn't really require an introduction. He's a senior diabetologist from Delhi, and he's a speaker and contributor to major decision making in multiple, whether it's RSSDI or in fact any major. If you look at this, he's a member of the ACE International Committee in 2014-2016. He is also director of the Advanced Certificate Course in Diabetes, and he has published both national and international journals. So a very warm welcome to Dr. Mukher.
Thank you, Dr. Alvina. Thank you, chairpersons, for those kind remarks. Good afternoon and good evening, friends. At the outset, I would like to thank Diabetes India and especially Dr. Bansi for this opportunity. And it's always, great pleasure to be among friends, and that too after a long period of virtual meetings. Today I am going to talk on 25 years of Icarus in India. We know Icarus is an alpha-glucosidase inhibitor. It has been in use, but somehow in the recent past, the visibility or the use of AGIs, specifically Icarus, was not very prominent, despite it has its own benefits and its own relevance in Indian diabetes management. So this is my disclosure slide, and this is a bio-sponsored presentation. So Icarus was actually approved in India first time 1997. So it is almost 25 years that we are using Icarus. It was approved for type 2 diabetes and also approved for use as adjunct to insulin in type 1, and also approved for management of IGT in 2006. In fact, this is one of the two drugs, metformin and Icarus, which are approved for management of IGT or pre-diabetes. Across the globe, it got its first approval in 1990, and it is now approved in almost most of the countries across the globe. Now, the concept behind using alpha-glucosidase inhibitors or hydrolase inhibitors was that if we look at dietary management of diabetes, it is usually disappointing, and we are not able to control glucose or glycemia well with only dietary interventions. The eating habits or nutritional behavior is also very difficult to change, and the understanding about the nitty-gritty of dietary management is also difficult to understand at patient level. So all this leads to unsatisfactory management of type 2 diabetes if you are using only dietary intervention. So idea was if we intervene with the effect or impact of diet on glucose levels, maybe we can improve the glucose excretion or the glycemic control if we have some molecule like this, and this led to development of enzyme inhibitors of glycosylases or glucoside hydrolases enzymes, and Icarus was the first one. So what it does is it blocks the degradation or digestion of polysaccharides and disaccharides to monosaccharides, and we know that all carbs need to be digested to glucose or to get absorbed into the circulation. So by blocking the breaking down of polysaccharides, it led to a delay in degradation of polysaccharides to monosaccharides and led to a decline in the rise of glucose that happens post-meal. So there was delay in the intestinal carbohydrate absorption, leading to lower postprandial hyperglycemia, and this also led to decreased need for insulin to control glucose and leading to improved insulin sensitivity. And the undigested carbohydrate that is delivered to distal gut has also been shown to improve the GLP-1 levels and gut microbiota, which I will show you some data during this presentation. So we have seen three AGIs in clinical practice in India. Acarbose was first, then we had Migritol, now we have Gogibos also. The difference is Acarbose is a bigger molecule. It is a competitive inhibitor of polysaccharide enzyme, oligosaccharidases and disaccharidases, and it competes with polysaccharides for the enzymes. While the Gogibos and Migritol are smaller molecules, and they compete with only the disaccharidases. So the blocking of alpha-glucosidase enzymes is higher with Acarbose as compared to Migritol or Gogibos, and that is why it is more efficacious in terms of reducing the glucose levels of postprandial hyperglycemia. Also, it reduces postprandial hyperglycemia by insulin sparing mechanism. We know that in Asians or Indians, we have a problem with the first phase insulin response, and we have compromised first phase insulin response in most of type 2 diabetes patients. And by lowering the postprandial hyperglycemia, it acts by insulin sparing mechanism. The insulin requirement is decreased, and it leads to improvement in postprandial hyperglycemia as well as the better insulin sensitivity. Now, in next few slides, I will take you through the evidence for Acarbose as monotherapy in glucose control, add-on to metformin, and there are certain benefits beyond glucose control that have been seen by in various studies in terms of usage of Acarbose. So, coming to the monotherapy data, the initial clinical trials clearly showed that it lowers fasting as well as postprandial, more remarkably the postprandial glucose, and significant reduction in A1C as compared to placebo when used as monotherapy. And the slide I am showing you is a meta-analysis from the Cochrane database, systematic review and meta-analysis of 28 placebo-controlled randomized trials, showing that it gives you a A1C reduction of almost 1% and a postprandial glucose reduction of almost 40 milligrams per deciliter, which is significant. Now, this was another meta-analysis from various studies done in the Western and Eastern population. We know that largely the Eastern population and the Asian population, we have large consumption of carbohydrates, while in the Western population there is more of consumption of meats and protein, less of carbohydrate consumption. So, if we compare the impact on the glucose levels or A1C reduction between the Eastern population and Asian population compared to Western population, we saw almost 1% higher A1C reduction using Acarbose in the people who were in the Eastern population because of the large amount of carbohydrate consumption. This was a study which looked at the Indian type 2 diabetes patient. This was part of the glucose VIP multinational real-world evidence study, which involved more than 15,000 patients. Of this, almost 2,000 patients were from India, and they were subjected to Acarbose therapy, and the change in A1C and glucose levels was measured at 12 weeks. That is 3 months. So there was 1% A1C reduction in people who were given Acarbose versus placebo, and there was a significant 74 milligram reduction in the postprandial glucose level and almost 30 milligram or 40 milligram per deciliter reduction in the fasting glucose levels. Another study, which was published in Lancet almost 7-8 years back only, this looked at the combination of Acarbose compared to metformin as the initial therapy. And this was again open label non-inferiority trial done in almost 800 patients in China. 48 weeks follow-up study showed that there was significant reduction in A1C, which was similar to metformin. It gave better postprandial reduction as compared to metformin, slightly lesser fasting glucose reduction as compared to metformin, and the body weight reduction was shade better than metformin. So it was, comparing with metformin, it was equally efficacious if you look at metformin. And the studies from different, molecules, monotherapy molecules, have shown that it gives you almost similar A1C reduction as seen in these studies using DPP-4 inhibitors or SGLT2 inhibitors also. If you look at the data from DPP-4 trials or SGLT2 trials, all these molecules have given you almost 1% A1C reduction across board various trials. Now, this was another interesting study called STOP NIABDM study, which was published way back 2002, and this was done in the time when the classification of diabetes was insulin-dependent diabetes and non-insulin dependent diabetes. And A-carbox was given to people who had pre-diabetes or impaired glucose tolerance. So in the follow-up of almost 3.5 years, there was 25% reduction in the incidence of new onset diabetes in people who were exposed to A-carbox, and also there was 35% higher chances of reversal from IGQ to normal glucose tolerance in people who were given A-carbox. Now let us see what happens when it is added on to metformin. As add-on to metformin, again this was a phase 3 study done in India involving 230 type 2 diabetes patients followed up for 12 weeks. A significant reduction in fasting glucose when added on to metformin, significant reduction in postprandial glucose, and additional A1C reduction of almost 0.7% when added to metformin. This is another study which looked at the comparative data between add-on of A-carbox versus voglibose when added to metformin, and showed that A-carbox had a better glucose lowering potential and better A1C reduction as compared to voglibose when added to metformin. Now, this is another very important meta-analysis which looked at the impact of various glucose lowering agents when added to metformin. And this was a meta-analysis from large number of trials from where the data was used from Medline, MPACE, Biosys, Cochrane database, and a lot of Chinese database where A-carbox has been used widely. And if you look at this, onto the left of the slide, you will see the A1C lowering. And the A1C lowering of potential of alpha-glucosidase inhibitors, which the molecule used was A-carbox, was similar to sulfonylureas, meglitinides, DPP-4 inhibitors, SGLT2 inhibitors, and so on. While the hypoglycemia risk was significantly lower in people who were given A-carbox as compared to other glucose lowering agents. Now, this is another study which looked at the comparative efficacy of A-carbox, DPP-4 inhibitors, and SGLT2 inhibitors, and sulfonylureas when added to metformin. And again, similar A1C lowering efficacy. This was a network meta-analysis of almost 62 randomized controlled trials involving more than 32,000 patients. And it showed similar A1C lowering efficacy as compared to sulfonylureas, DPP-4 inhibitors, and SGLT2 inhibitors. Now, let us see what is additional benefit beyond glucose control. So, as I showed you, the mechanism of action is by blocking the effect of alpha glucosidase enzymes on breakdown of the polysaccharides and disaccharides, and this leads to undigested glucose, the polysaccharides or carbs being delivered to the distal part of that. And the presence of these undigested carbohydrates in IM possibly leads to GLP-1 secretion, increase in GLP-1 secretion. This was shown in the study that there is increase in GLP-1 level after 60 minutes of ingestion of ACARs, and this possibly helps in reducing the postprandial hyperglycemia and also reducing the glycemic variability. This was a study where people who were already on aloperidol 25 milligrams were given additional ACAR dose and subjected to CGM for 3 days. And the CGM data clearly showed that there was significant decrease in the glycemic variability in people who were given ACAR dose as compared to those who were not given ACAR dose. And if you look at, there was significant, look at the data. This is a different study where ACAR dose was added to people who were already on metformin with a gliptin combination and having A1C in the range of 7.5%. And almost 50 patients from clinical research units in 3 hospitals in Italy. This is not a Chinese study, this is a European study. And these people were given additional ACAR dose, and followed by that they were subjected to CGM again. So there was significant reduction in the mean amplitude of glucose excursion, that is glucose variability. There was significant reduction in the standard deviation. There was significant decrease in the time above range, and there was significant increase in the time in range in people who were given additional ACAR dose. This was another study where ACAR dose was added to people who were already on premix insulin and was compared to addition of metformin versus ACAR dose in people who are not optimally controlled on premix insulin. And addition of ACAR dose was associated with significant reduction in the glycemic variability measured by decrease in the coefficient of variation, decrease in weight, and decrease in the standard deviation. So ACAR dose addition has been shown to not only lower glucose levels, lower A1C levels, reduce the risk of hypoglycemia, but also reduce glycemic variability. Now let us see what is data about the gut microbiota. So addition of ACAR dose has been shown to improve the gut flora in the favorable direction. I will not go into the details of individual genus, these genuses of various microbiota. But important thing to understand is that it improves the density of microbiota, which favor decrease in glucose levels, decrease in inflammation, and improve the liver flora levels normal, and decreases the largely the bacteroids. Bacteroids are considered negative species or the harmful species. So it helps in improving diabetes, it helps in improving the inflammation, that is reduces inflammation, and helps in reducing weight also. And this may be one of the actions on microbiota. This is again, same data from another study. Now let us look at the impact on the cardiovascular events. So this was the A study or ACAR dose cardiovascular intervention study, where the patients who were treated with ACAR dose in addition to either existing therapy or treatment-naive patients or even patients who were having IgD, they were given ACAR dose. Only condition was they should not be on ACAR dose therapy for 3 months prior to the trial. And they were followed up for 5 years for the cardiovascular outcomes. And the cardiovascular outcome was, first one, the primary endpoint was 5-point endpoint including 3-point MACE, hospitalization due to heart failure or hospitalization due to unstable angina. And then we had multiple secondary endpoints. And if you look at the data, the ACAR dose did not increase any risk in terms of increasing the risk of cardiovascular endpoints or the renal endpoints also in this particular study. This was another study, media study, which looked at the impact of ACAR dose in reducing the cardiovascular events This was the meta-analysis of 7 double-blind placebo-controlled studies involving more than 2,000 type 2 diabetes patients followed up for 1 year, showed there was 35% reduction in the all cardiovascular events and 64% reduction in the myocardial infarction. This was, again a study which looked at the real-world evidence of acarbose as second-line agent versus metformin sulfonylurea combination, and showed that people who were given acarbose as second-line agent had lower risk of hospitalization due to stroke, hospitalization due to atherosclerotic cardiovascular events, and hospitalization due to myocardial infarction. All were lower in people who were treated with acarbose added to metformin. This is another study which was Beijing community study, 10 years follow-up. The study involved almost 1,400 patients in the acarbose therapy and almost 330 patients in the non-acarbose therapy. The study was done in the outpatients where the patients were followed up for a period of 10 years. And the study showed that at the end of 10 years, people who were on acarbose therapy had a significantly lower, all-cause mortality, which was because of the significant lowering of the myocardial infarction. Recent data in patients who had COVID and were hospitalized, there was significant reduction in the risk in people who were already on treatment with acarbose or acarbose metformin combination as compared to those who were not on that treatment. So acarbose or alpha-glycose inhibitors are already part of clinical practice recommendations. In fact, if you look at the ideal guidelines, it recommends alpha-glucosidase inhibitors as an alternative to metformin if metformin is not tolerated as first-line drug. And people who are already on lifestyle intervention and metformin, you can consider sulfonylureas or alpha-glucosidase inhibitors or DPP-4 inhibitors or other agents. And either ADAs are also recommended as second-line drug by these guidelines and of course in the RSNA clinical practice recommendation. So to sum up, acarbose demonstrates a clear-cut significant glucose lowering efficacy with good safety profile and is efficacious in broad range of patients irrespective of whether the background drug is metformin or insulin or baseline A1C, duration of diabetes, body mass index, age, long-term usage and so on, and has been shown to be CV safe. And that I think that is important profile for any molecule to be used as a second-line agent in type 2 diabetes management. With that, I conclude my presentation. Thank you. If there are any questions, I think we'll have at the end of session.
End of the session. So, our next speaker is Dr. Sunil Gupta. He is going to speak on diabetes as comorbidities from bystanders to driver of heart failure. He is a well-known speaker, and so Dr. Sunil Gupta is the National President in Diabetes in Pregnancy Study Group India LFC 2021-22. He is the National Treasurer RSSDA 2019-22. He has received various awards, particularly mentioning Guinness Book of World Record in 2013 and Limca Book of Record in 2016. And he is a National Executive Member of RSSDI, and he has published many papers in various international and national journals. So, over to you, Dr. Sunil Gupta.
So thank you very much, Chairperson, for this nice introduction. Thank you, Bansi Bhai and the whole team of Diabetes India for wonderful invite and as well as the venue which everyone wants to come for. My today's talk is diabetes as a comorbidity, from bystander to a driver for heart failure. And this particular session has been sponsored by Novartis. That's my disclosure. Now we know that diabetes is an independent risk factor for heart failure, and recently we have started realizing this fact in last 5 to 7 years, almost a decade. That diabetes increases the risk of heart failure, almost 5 times higher in women and 2 times higher in women. It is highly prevalent in patients with diabetes. 25% in chronic heart failure, in acute heart failure almost 40%. And 4 times prevalence is higher than the general population when it comes to diabetes. That means it is suggesting that diabetes has a pathogenic role in heart failure. It is not just the bystander, that is rather an unwanted path leading to heart failure. We know that diabetes, when we talk about type 2 diabetes, you have hyperglycemia, insulin resistance, and hyperinsulinemia, and through various pathways, it becomes a triggering factor to have a patient with the coronary artery disease, or some patient may develop an ischemic cardiomyopathy, and this is not an uncommon complication of diabetes, very common complication. And then we also have various other mechanisms. Maybe it is cardiomyocyte hypertrophy causing LDH, maybe it is RAS activation causing fibrosis, maybe some other electrolyte related mishandling of the calcium, fatty acid utilization, formation of the advanced glycosylated end products, autonomic dysfunction. They all may lead to cardiomyocyte hypertrophy, and the LDH may be responsible for heart failure. So it's an emerging area of interest. Possibly till this date we did not have many of the molecules from when it comes to diabetes. And I still remember many of the time patient used to be asked to go for echocardiography. He used to come with diastolic dysfunction, and we as a clinician have never given value to that. And we used to say diastolic hypertension, diastolic dysfunction is okay, don't worry about it. And we used to usually forget about it. Possibly we did not have any discussion, neither in-depth learning on this particular topic. So only over last around 10 to 15 years, it became evident that heart failure incidence and prevalence is high in patients with pre-diabetes as well as diabetes. It's a second frequent reason for initial clinical presentation of cardiovascular disease. The presentation with heart failure is more frequent than stable angina and non-fatal MI. So the prevalence is high, and that's why today's discussion is all going to be on diabetes and heart failure. How do we manage a case of heart failure patient with diabetes, the case study, and we'll have some concluding remark. Diabetes and heart failure, they coexist as a strong impact on clinical management and prognosis. Now you have to be keeping your eyes open. I still remember when we got Biaxazone and Rosiglutasone. That time we used to see for echocardiography, we used to see for LV function before starting glitazones, because of the awareness on this that this drug might precipitate congestive heart failure. And from that learning, echocardiography has become one of the tool of doing in most of the patients with type 2 diabetes. But after this SGLT2 inhibitors and RB has come, our understanding has got further strengthened to be put into the clinical practice. So heart failure will reduce ejection fraction, independent predictor of the fatal and non-fatal clinical outcome in patient with type 2 diabetes. And the worst clinical status and increase all cause of cardiovascular morbidity in patient with diabetes if we have heart failure with reduced ejection fraction. So if you have HF-REF, then HF-REF, then you have in diabetes, it is one of the important parameter, important cause for increased cardiovascular morbidity. So type 2 diabetes, if you talk about the relationship with heart failure, is frequent in patient with heart failure, occurring almost 40% of the hospitalized patient for heart failure and up to 30% of those with chronic heart failure. That means almost half of the population who are admitted in the hospital with heart failure have diabetes. If you talk about the impact on the clinical outcome of heart failure in 1 year, the 7% increase in the risk of cardiovascular death and 27% increase in the risk of hospitalization for heart failure. So long-term morbidity, like I said, about 50% among the people with heart failure have diabetes. So So that means every second patient of heart failure has diabetes, and the prevalence of heart failure and diabetes tells you around 40%. And if you see whether it is all-cause mortality, cardiovascular mortality, all-cause mortality along with the hospitalization for heart failure as a combined endpoint and the hospitalization for heart failure, it goes on increasing. The hazard ratio goes above 1 when you talk about this and when you compare it with diabetes versus non-diabetic. Still, the heart failure is unfortunately the frequent but the forgotten complication of diabetes. We always talk about microangiopathy, we talk about macroangiopathy, and we keep ourselves only to cardiovascular disease, but heart failure is being ignored up till now. So unmasking heart failure, putting your patient with diabetes is imperative. High prevalence and the significant morbidity and mortality of heart failure mandate early in identification and to provide the appropriate and timely therapy. 50% of the individuals with left ventricular systolic dysfunction remain undiagnosed and untreated. Clinicians should not overlook diabetes patients with stable coronary artery disease as they may present early symptoms like shortness of breath. Early diagnosis and immediate treatment can help to delay or prevent the progression of the debilitating disease. Now, we have some now guidelines for management. More and more international and global recommendations are changing, and they are now talking about the management strategies for heart failure along with the other things in diabetes, other complication of diabetes. So here is an example of Mr. Vikas. 62-year-old man with a history of diabetes since almost 2 years, so very recent onset diabetes. He is little obese, 26.6 BMI, already on metformin and vildagliptin combination. During the regular checkup, the patient complained about the swelling on the legs, shortness of the breath, typical feature of heart failure or fluid overload. And his ejection fraction was found to be 23%. Now such cases are not rare in our regular clinics, and we should be little open in accepting this fact and little aggressive in evaluating such cases as a clinician. Blood sugars are well controlled, NT-proBNP is little on higher side, systolic blood pressure was normal, eGFR is 63, creatinine 1.15. Based on this clinical examination, he was diagnosed to have HFrEF and along with the diabetes, HFrEF. Now, however, there is a need for better therapy because he is only on metformin and vildagliptin. Several heart failure therapies such as beta blockers and diuretics might aggravate dysglycemia. We are aware of this. So, newer therapy need to be added in such cases. What should the treatment approach for Vikas? Whether we should be just adding ACE or ARBs, RB or SGLT2 inhibitors? Let's learn from this. When you see a patient like him, initiate the patient with RB as the first drug of choice. Now, ACC experts, now I am not a cardiologist, but then these are the guidelines which we need to respect. ACC expert consensus guidelines 2021 says that RB, which is sacubitril and valsartan combination, is preferred RAS inhibitor over ACE inhibitors or ARB for HFrEF. And in HFrEF patients, if you have LPA less than 40% or the patient has NYHA class 2 to class 4 heart failure, administer RB in conjunction with the other antidiabetic therapy for heart failure in place of ACE or ARB. And so we have indication that we can directly go to RB, which has been recommended by the authorities. Now these are the ACC 21 consensus which indicate the use of RB over ACE and ARBs. Initiate the initial doses should be if the previously patient is already on ACE inhibitors. Most of these patients are already on ACE inhibitors, and if you talk to a cardiologist, they prefer giving ACE inhibitors as a drug of choice. Ensure that 36 hours of before the initiation, when you want to stop ACE, then select the initial dose of the ACE or ARB. If the patient is taking equivalent to less than 10 milligram, daily of enalapril or equivalent dose of the valsartan, then 50 milligram twice a day we should be giving. And if the patient is taking equivalent dose of more than 10 milligram of enalapril, then equivalent dose of more than 160 milligram valsartan, that is 100 milligram to be given. Because this particular combination RP is already having ARB, so we have to stop ACE in this patient. In 2 weeks, assess the tolerability. If possible, increase the dose to the almost 200 milligram. Monitor the blood pressure, renal profile, electrolytes after initiation of the therapy. So this is one of the combination where you can set because this becomes a kind of one of the best therapy and one of the preferred therapy. ARNI has an expanded role focused on the optimizing the therapy of HFrEF. The superior clinical evidence of ARNI includes the de novo therapy in patient with those patients who are already who are not on ACE but ACE or ARBs, rapid improvement in the patients of symptoms, physical functioning and the quality of life. Cardiac reverse remodeling effect has been shown independent of the background therapy with ACE or ARBs. Additionally, ARNI shows beneficial effect in heart failure patients with diabetes. Now, when you have, this is one of the possible mechanism where you have ARNI and AT1 receptor blockage. It improves insulin sensitivity through leptin acid inhibition. It has through various mechanisms of dialysis. Then you have bradykinin increase GLP-1 skeletal muscles, cyclic GMP, decreasing DP4 activity. It ends up increasing insulin sensitivity, better lipid mobilization, increase insulin metabolism, increase adiponectin, blood glucose levels are reduced, postprandial lipid oxidation is reduced, and lipid increase, and muscular oxidation capacity is also increased. So overall, it also increases insulin sensitivity and attenuates the lipolysis, anti-hyperglycemic effect, facilitates lipolysis, and increase beta cell function. So ARNI is a drug which improves insulin sensitivity, favors the lipid mobilization and oxidation by augmenting the natriuretic peptide. So ARNI positively impacts the clinical outcome in HFrEF irrespective of the glycemic status. It provides a 20% reduction in the risk of CV death, 20% reduction in the risk of hospitalization for heart failure, and 17% quality of life improvement probability within 8 months period. It also enhances the glycemic control in patients with diabetes with having HFrEF. 0.14% greater between the group reduction in HbA1c concentrations over 3 years with ARNI and 29% reduction in new use of insulin therapy. That's another benefit. Exact mechanism is not known. What about the SGLT2 inhibitor? I think you must have heard this talk multiple times in at least in last 5 to 7 years when SGLT2 everyone is, earlier we were all gliptinized and then we were gliflonized. And now cardiologists have also entered into the field. So ACC 2021 consensus recommends using now SGLT2 inhibitors after using HFrEF therapy in patients with diabetes as a comorbid condition. And the suggested action is that it optimizes the HFrEF therapy. First you have to optimize the therapy by giving ARNI and sometimes ARNI beta blockers. Then SGLT2 inhibitors to be added to it and consider to consult the diabetologist or endocrinologist. So SGLT2 inhibitors as an add-on therapy for HFrEF patients is this is again recent consensus guidelines which says they are added as a part of therapy for HFrEF patients who are already receiving ARNI, beta blocker, and MRI, that is aldosterone antagonist. SGLT2 inhibitors are initiated as an add-on therapy after the preferred first-line therapy ARNI for HFrEF patients. Now, rationale for the use of SGLT2 inhibitors is DAPA study. I feel we started when it comes about SGLT2 inhibitors, we started as a glucose-lowering therapy, then we came across the cardiovascular CV outcome trial and shown that it reduces the morbidity in patients of CV and MACE and a lot of other benefits. Cardiovascular benefits have been shown. One of the others, even shown the cardiovascular death is being prevented. So cardiovascular benefits we have shown, then we have seen the renal benefits, and now we have seen the heart failure benefits. And then we are also going to see NAFLD, role of SGLT inhibitors in NAFLD, Alzheimer's disease, and whatnot. So this is here you have a data study which has demonstrated reduction in risk of worsening heart failure or death from the CV cause, cardiovascular cause with dapagliflozin, and Emperor, which is empagliflozin trial, EMPA has shown there is composite endpoint of CV death and hospitalization with heart failure with empagliflozin. So they all have favored DAPA as well as the DAPA-HF, and Emperor reduced has proved that SGLT2 inhibitors can be added to in patient with heart failure. And these are the guidelines for the use of SGLT2 inhibitors. Initiation and the dosing of SGLT2 inhibitors. If the patient is already on ACE or ARB and ARNI, and the evidence-based beta blocker with diuretic has been needed. For patient meeting eGFR criteria, initiate DAPA 10 mg or empagliflozin 10 mg. eGFR more than 30 for DAPA and more than 20 for EMPA before initiation. So these are the indication. Whenever you start SGLT2 inhibitors in patient with heart failure, also take care that you check the eGFR. Indications: HFrEF patient with less than 40 ejection fraction with or without diabetes, or NYHA classification with class 2 to 4 heart failure, or administered in conjunction with the background therapy for heart failure and glucose-lowering therapy. I feel with this I stop here. This is the combination of ARNI and SGLT2 inhibitors. So it has shown better clinical outcome compared to conventional therapy. When you combine ARNI and SGLT2 together along with the other background therapy, we talk about cardiovascular death or hospitalization for heart failure, cardiovascular death, hospitalization, hospital administration for heart failure, and all-cause mortality. All of them are in favor of this combination when you give ARNI and SGLT2 inhibitors together. And it favors the comprehensive therapy. The comprehensive therapy halt or delay the clinical progression of hospitalization for heart failure compared to the conventional therapy for heart failure. The combination of ARNI and SGLT2 has shown better event-free survival in patients with HFrEF compared to conventional disease. And this is those patients who are of age 55 or those who are age above 65. In both the cohort, elderly patients as well as those who are 55, if you see the combination therapy, the comprehensive therapy has a better survival versus the conventional therapy. The combination of ARNI and SGLT have shown better overall survival in these patients. I feel I'm in time or I have to wind up?
So we are out of time, sir. We are out of time.
I just want to say 1 minute.
Yes, sure.
Okay. The combination of ARNI, beta blocker, MRA, and SGLT inhibitors can be used as a new therapeutic extender in patients with HFrEF. I feel this is my last slide, so I have taken less than 1 minute now. So, if HFrEF patient with diabetes like Vikas, choose optimal glucose-lowering therapy for a better outcome. Initiate with ARNI, SGLT inhibitors to be added. Combination of ARNI, beta blocker, MRA, and SGLT inhibitors can be used as a new therapy standard in patients with HFrEF and diabetes. I feel this is what was the last slide. Thank you very much for your patience.
Thank you very much, Shaukat Sadikot, for a very lucid talk on SGLT2 inhibitors. With that, I would like to conclude this session, keeping in view the time. We are running late, and the other speakers for the next session are here. So, Dr. Gupta, we will take the discussion on a personal one-to-one basis and move ahead with the next session. Thank you so much for the patience.